so much, everyone. I am Sarah Pankineer-Weld. I'm the professor of comparative literature W40, Young Humans, Introduction to Childhood Studies. And as we turn in our class to today's topic, childhood and medicine, children are not small adults, I am delighted and honored that we have the privilege today of a visit from our special guest, Dr. Dan Brennan, who is a practicing pediatrician here in Santa Barbara for 25 years. Welcome to campus.
Thank you.
And thank you so much for visiting us today. I'm going to give a brief introduction to Dr. Brennan, and then he will take it from there. So Dr. Dan Brennan is a board-certified general pediatrician who has been practicing at Sansom Clinic, now Sutter Health, since 2001. He is the medical director of pediatrics, Children's Health Service Line medical director for the Sutter Health Greater Central Coast Division, and an advisory committee member for the California Immunization Coalition. In 2014, he founded Strive for 95, a community collaboration to get vaccination levels about 95%, and in 2015 was named Santa Barbara County Physician of the Year for his work. Dr. Brennan is also a former president of the Dos Pueblos Little League and has coached over 60 youth sports teams, so another youth and childhood connection there. And these days, he has fun refereeing soccer and creating health-related social media content. And now we will shift to Dr. Brennan's presentation.
All right. Thank you guys so much for having me. This is a pleasure. I grew up in Santa Barbara, and so I spent a lot of time on campus. My wife and brother both went to school here, so we've got a lot of Gaucho connections. It's really fun to get to come. So thank you for the warm welcome. I am Dan Brennan. I am a board-certified general pediatrician. We'll talk a little bit about what that means and how to get there. I've got a couple of administrative titles with my department and Sutter Health, and then most recently got a chance to be part of something called the California Immunization Coalition, which is an advisory group for the state and vaccine policy, which is timely these days. So I just want to tell you a little bit about myself personally, because I think it'll kind of connect into the presentation a little bit. So I put together a little bit of a collage for you. So Sutter Health is who I work for and work with. This is my family. I've got 3 boys. This is Josh. He's a senior at USC. Matt, who is a sophomore in high school, and Andy, who is a freshman at USC. And this is my wife, Yael, who is a Gaucho. To make things odd, I went to UCLA, so we've got a little rivalry in the house going. These are a couple of UCLA basketball legends. Jamal Wilkes, who also is an NBA Hall of Famer. Gary Cunningham, who was a UCLA player, coach, and was a UCSB athletic director for a really long time and still involved. So this is another Gaucho connection. My son Matt and I refereeing. This is one of the sports teams I got to coach. This particular team made it all the way to the Western Region tournament in Bend, Oregon, which is a big deal. I do have a health column that I will write time to time in Newshawk, if you're familiar with that publication locally. And then we'll talk about one of my community advocacy projects, Strive for 95. So why does this topic matter, and why was I so excited when I heard that this is what you guys want to talk about? My first day of my pediatric training, we were all sitting down, and the first thing they said to us are, children are not just small adults. So literally that was my introduction to pediatrics when I was in medical school. First thing that was said in the rotation, and that really stuck. It was one of the things I thought I was interested in, but I found through that 8 or 12-week process that it was definitely what I wanted to do. The reason that it's important is that there's so many things that are different about children. We're going to get into those a little bit, but when we assume that children are just small adults, that not only gives credit to children for what they can accomplish, but sometimes it's also punitive. People sometimes hold them accountable for things that they shouldn't be accountable for, and that's just not fair. My field of pediatrics exists because we need to learn about the growth and development of children. We need to learn about how illnesses affect them so that we can do the best that we can do for them in helping them grow and develop, and also advocate for them. And these differences can have impacts on kids' health, education, public policy, and ethical questions as well. So I just start with, what is a pediatrician? We have somebody here who's interested maybe in pediatrics. And so I would say these are the things that are most important when we're describing what a pediatrician is. So a pediatrician is a doctor that specializes in the physical, mental, and social health of children. Some of us care for kids from birth to 18. There's some areas where it might be birth to age 21. It's a little bit regional. In our practice, it's basically birth to age 18 or until somebody graduates high school and goes on to college. We're trained specifically to understand growth, development, age-related milestones. So when is a child supposed to sit up? When are they supposed to pull up to stand? When are they supposed to walk? When are they supposed to talk? To help identify if somebody's falling behind, then we can intervene and help out. We recognize that children are different both biologically and physiologically. We provide not only preventive care, but we also provide care for somebody when they get sick, somebody who has long-term illness, and we're also just there as a sounding board for families or kids that need us. And so we do this through a number of different things, and what we call anticipatory guidance, which is a lot of things. Here's how to safety-proof your house. Here are the things we expect your child to do over the next year so that you can be aware of it and help foster their language skills or their reading. And then we also work with families on health education and advocacy. So these are two things that I took to heart. So the health education part I do a lot through some of the health writing that I do, and then the advocacy we'll talk a little bit about. And then I just thought for those of you who are maybe interested in medicine or have somebody who are, I just want to take you through what does it take to get from here to there, because nobody ever told me that when I was in college. I had to figure it out on my own, so it would have been nice to know early on. So you get your 4-year degree, you apply to medical school. You don't need to know what kind of doctor you want to be at that point. You just need to know that you want to go to medical school. Then you go through the process to get into medical school. Once you're in medical school, your first 2 years are going to be a lot of classroom learning, so a lot of lecture-based, a little bit of clinical, and then your second 2 years are going to be almost all clinical. So it's all taking care of patients, it's working in an outpatient clinic setting, it's working inpatient in a hospital, and you're going through all the different rotations. So internal medicine, family medicine, pediatrics, surgery, all of the different specialties that you're interested in learning about. So cardiology, heart, gastroenterology, the digestive system, things like that. And then when you get to about your 3rd to 4th year, you start thinking, what do I want to really do? And then you start focusing in on that, and you apply to something that's called a residency. So your residency, it could be as little as 3 years if what you want to do is just become like a primary care doctor. And then so the process there, you get into your residency. And then as you're going through your residency, if you decide, I want to specialize even further, then that's when you would maybe go on and do what's called a fellowship. And then you can spend another 3 to 7 years depending on what you're doing. So it can be quite a long time by the time you're done, depending on what you want to do. So for me, I went to UCLA. I went to Albany Medical College in upstate New York. And then for my residency, I came back to Los Angeles, and I was at Cedars-Sinai. And then was lucky enough to get to come back to Santa Barbara, practice in the same practice that I was in as a child, and I actually got to spend my first 20 years with my own childhood pediatrician, who was a mentor all the way. So if you're interested, don't feel bad about reaching out to some of those people in your past who have been helpful for you, because they want to help you. So let's get into what we're really talking about today. So children are growing from the time that they're conceived to the time they're born. Picture a small 6-7 pound baby. They're not even close to being developed. There's still a lot that's going to happen. So I wanted to give you a couple of ideas of things that we think about. So I thought it'd be interesting to take a look at what does the nervous system look like from the time somebody is born to the time they're an adult. Big changes. You're a month old, and this little pink area is your brain. That's pretty tiny. You can't really do much with that. But then as time goes on and you start developing more brain matter until finally you have this amazing thing here, which is an adult brain. So that's really important to keep in mind, because this will control a person's development, what they understand, and how we treat them. Have you guys ever seen one of these? Anyone ever? Does this look familiar to you? So you guys are probably old enough that you didn't really have these in the doctor's office. Everything might have been done electronically. But these are called growth charts. And so for the first 2 years, we've got this chart. This one is birth to age 24 months. This is the female growth curve. On the top, we look at length versus age on the bottom axis. And on the bottom part, we look at weight versus age. So this allows us, every time somebody comes in, to measure them and get data points, and it helps us figure out, is a person growing appropriately? Is a person gaining weight appropriately? Is a person on a growth spurt? And so we assign percentile values, and people sometimes get hung up on they don't have the highest percentile. It's not an SAT test. It's not a standardized test. You don't get a better grade from me if you're in a higher growth percentile. It's really just a tool for myself and parents to track growth. And so that's an important tool of what we do. Another idea is that our organs and immune system are also things that are developing over time. So that's why it's important to know what's going on, because we're not just dealing with an adult here. We're dealing with a dynamically changing child. So I've got a little case study for you guys. You guys are walking on campus and you come across somebody who's on the ground. They're crying hysterically. You happen to have in your backpack a little vitals kit, so you go and you check their pulse, you check their respiratory rate and their blood pressure, and you get these values here. Heart rate of 140, respiratory rate of 60, blood pressure of 80/40. I don't expect you to know what these things mean, but I just want you to keep in mind, how are we going to evaluate this? What does this mean? So what's normal? If you had encountered an adult on the ground that was inconsolable, had a heart rate of 140, respiratory rate of 60, and a blood pressure of 80/40, you're calling an ambulance and that person's going right to the emergency room because they're in bad shape. But if you encountered a 1-month-old baby who's crying and inconsolable, that's normal. Heart rate of 140, that's normal. Respiratory rate of 60, that's normal. And that blood pressure is also normal. And how do we know that? Because we've got lots of data tables. And so this is just an example of what we expect to see vital sign-wise for a baby that's just born, an infant, toddler, preschool, school age, adolescent, and then adult. And so these are all things that we have to learn, not necessarily memorize, but have an idea of what's normal, not normal, because it really makes a difference. And so it's nuanced, but it's really important to people like me that are taking care of kids. Same thing goes for laboratory values. So I had somebody in the office this morning, and I told them we're going to order some lab values. We were working up immune function and ordering some antibody tests. And I said, just so when the results come to your app, they're going to look weird. They're going to all be flagged abnormal because probably the results that they're going to give you, they're going to compare that to normal values that are adult values. They're going to be very different from their 2-month-old. And I wanted to mention that ahead of time because if you are a parent and you get results after hours and you look on your app and you see these results and there's no explanation for it, you might have a really uneasy night that night. And so that's one of those things that as we can get better with technology, we should be able to make sure that those lab values are programmed so that when you have a 2-month-old, it can pull in the 2-month-old data and show up. And I think that that's getting better. It kind of depends on the lab and the health system that you're part of. So medications, another thing that is really specialized. So small bodies, kids' bodies metabolize drugs at a different rate than adults do. So when we prescribe medication, we will prescribe medication based on a child's weight. So it's not necessarily you pick out your antibiotics and you're giving somebody 875 milligrams of Augmentin. We have to calculate out the dose based on a child's weight. I used to have a calculator that I would keep in my pocket. I would have to pull it out and do calculations every time. The new electronic health records pretty much pull it up automatically, and then I just have to look and do a little mental math and make sure that that sounds correct. We need to see what form our patient's going to take it. So do we have a child that's going to take liquid, or does it taste so gross that you're never going to take it, and we need to be creative and maybe we get them a pill that can be crushed, or they can go to a specialty compounding pharmacy and have that amount made into a powder for them. Chewables are generally nasty, so I don't usually prescribe those. But the big take home here is that adult dosing for medications is not equivalent to child dosing. So again, something we need to memorize, be familiar with. The new health system software is pretty good at pulling out those things for us to help us with that. And the result of not paying attention to that could be toxicity. Maybe we give too much Tylenol and we cause some liver damage. That would be bad. Or we underdose antibiotics and we can't treat somebody's illness and they get sicker. So these things have consequences. And then the advocacy part. we need people that are willing to do, and they're funded to have child-specific research. It's not good enough to just say, we have a clinical trial or research project going on for adults. We need to make sure that to the extent that it's ethical to do that, we can do these studies on children too, so we really know if it's effective for them. And then this is just an example of what parents might use. A lot of times we'll give this information, so if they do go home and need to give some Tylenol for an illness, they know what to give. And as you can see, there's lots of different forms that parents can get, so it's confusing. So if we don't talk ahead of time in the office about that, somebody might go to the pharmacy, pick up the wrong thing, give the wrong dose, and then again, we're back to the potential overdose. This slide talks a little bit about how children, teenagers are a little bit different in terms of how they digest information. And so when we're in the office and we have a patient there, it's important to make sure we're not only talking to the parent, but we're also addressing our patient too. It's important to know that younger children sometimes have really vivid imaginations. They can't really put things in context all the time, and so they may not really understand what we're saying. So we have to be careful about that. I have a very good example of that. When I was showing you the pictures of my kids before, my middle son, Andy, when he was 11, went over to a friend's house for the first time. And that friend's dog, for whatever reason, didn't like Andy and attacked him and caused a really significant facial bite. I was at the time coaching my younger son, Matt's soccer practice, got a phone call, was told what happened, left practice, gave it to my assistant coach, and I went over to Goleta Valley emergency room. It was pretty clear he needed to have a plastic surgeon come in, and so we requested that, and we were there for a few hours. When I got home later, my parents came over, we had a neighbor come over, bring some ice cream for the kids. Andy was all bandaged, nobody could really tell what was going on. And I was telling the story about how I went to the emergency room, I requested a plastic surgeon, she came in and she fixed Andy. What I didn't realize was my 8-year-old son, with his magical thinking, thought plastic surgery, oh my gosh, my brother now has plastic parts. And it makes sense, right? He's never heard of a plastic surgeon before, but he's watched TV, he's played games, he's thinking to himself, he's part human and now he's part plastic. And I felt awful because for a long time he held that inside, was really worried about his brother. It was a reminder to me that when I'm having these conversations in the office, I sometimes need to be careful with the words and language I'm using. And so sometimes I'll find another way to explain something or make a joke out of it if it's something that I think is going to try and diffuse the situation a little bit. Teenagers, we're going to go through this little chart in a second. As you get through high school, you're starting to think a little bit more as an adult, but maybe you're not quite there with thinking about consequences, impulse control, long-term decision making. And so I thought this was a really interesting study of the brain. I think this was from UCLA. And so just to orient you to this, if you guys have ever heard of something called the prefrontal cortex, it is the part of the brain here that helps us with executive functioning, helps us with concentration, decision making, helps us a little bit with impulse control and understanding long-term consequences. So anything here where there's red, orange, and yellow, this is all immature part of the brain, not yet developed. And then down here, the blues and purples are going to be a more developed brain. And so the take home here is when you are 5, you're pretty immature here. Decision making isn't as good as it's going to be. By the time you're a teenager, it's better, but it's not great. Think back to high school years and maybe some decisions you take back or things friends did that they wish they would do different. And by the time you're 20, you're pretty much there. You're not 100% there, but you're there. And I've seen that with my own kids. My son, who's a senior, who's 21, I've seen this. And it's really amazing to see this change. And you'll see that yourself. Maybe you do already. People who are a little bit more mature, I think probably already have this developed a little bit sooner. Some people who are maybe a little bit, they're not quite baked yet, they're not quite there, maybe in this range a little bit here. Emotional regulation. So my patients behave differently in an office than my friends who are family medicine or internal medicine physicians. My patients may come in and they're hysterical before I even walk in the room. I'm not sure why. Maybe they had a bad day. Maybe they're mad that they had to leave school or soccer practice. Maybe they know what's going to happen and it's not going to be super fun. Sometimes people come in pain, but they can't tell us what's going on. So there's a number of tools that we have. One of my favorite tools are these pain scales. So this is the one that we used when I was a resident in the hospital in my training. And so when you walk into a room and you want to know, are you having pain? How are you feeling? Sometimes kids can't tell you exactly how they're feeling, but they can point to this. And so if you can make a connection and they can point, then you can track how much pain they're in. Maybe that helps you determine if you're going to give more pain medication, or you can just track, do we feel like they're getting better or not, if you can see a steady improvement there. I think it's cool that Legos have their own pain scale. So if you ever know someone that's a Lego, that exists out there. And then I think the other thing to keep in mind is behavior often can communicate distress. So Dr. Weld might be aware of this kind of situation, but your kid has a cold, runny nose, cough. They're not feeling great, but they're not feeling too bad. A week into it, maybe they don't want to go down for sleep, or they keep waking up in the night. Maybe they're just crying and they can't tell you why they're crying. But you know as a parent, like something's not right. The behavior is off. That's usually enough for somebody to come see us. We're able to take a history, do an exam, put things together, and in that scenario probably has an ear infection. And so we're going to look in the ear, we're going to see that eardrum is red, it's bulging. We have an explanation, we can prescribe an age-appropriate or dose-appropriate medication, and we'll get that child feeling a little bit better. Another thing to keep in mind here is that our patients aren't responsible for decision making. It's important for us to include them in decision making, but ultimately their parent or guardian is the one that's going to sign off on care. If a procedure needs to be done, that parent is the one that is going to decide. And so adults make decisions for them. And so for that reason, it's really important for us as much as we can to make sure we're including our patients in decision-making process. And so for those kids that can understand it, they deserve an explanation on their level. So it's important to make sure that we're sitting down with them, eye level, so we're not standing up and we're intimidating, overshadowing someone. So sitting down is definitely important. It's important to make sure that we're showing them respect. They might be having a miserable time because somebody's poking and prodding and they're not happy. If I'm having a bad day, it's not okay for me to put that on them. I need to take a deep breath and make sure that I'm showing them some respect. And I need to make sure that they also have a voice. So the example here might be somebody coming in. Has anybody ever had a wart frozen? Yeah. So not the most comfortable thing in the world. Sometimes parents come in and they're like, we're coming in because we're tired of dealing with that wart. We're having the doctor freeze that thing off today. And the patient might be, okay, that sounds good to me, but what does that mean? Or they may be like, does it hurt? If something hurts, I'm always going to tell somebody that it hurts. I'm never going to say, it's not going to hurt. Because as soon as it hurts, I've lost that trust with them. They're not going to trust me anymore. And so that's really important. And they may not trust adults or other people in healthcare anymore if somebody lies to them. So I have to tell them, it's going to sting. It's going to blister. It's going to scab. But the nice thing is you're not going to have to keep putting those Band-Aids on every night. The nice thing is we can probably get rid of it a little bit sooner if it's bothering you. If that child says, it really doesn't bother me, I don't want it done, then it's my job to try and advocate for that child that maybe that's not the right thing to do today. Here's some other things that we can do. If you decide in a week or two that you want to come back and do it, we can always reconsider that too. So I think it's always important to make sure that we're trying to make sure that our patients have a voice as well. I'd like to talk a little bit about just some social things. So as we were talking about, children are dependent upon adults for their regular care, their health care, their safety, and for advocacy. Without having adults, there's nobody else looking out for kids. And a person's environment really impacts their being. If a person is growing up in poverty, a person doesn't have food, they don't have stable shelter, that's going to change the way that they grow up and their experience and their ability to get ahead. And I think that's an important thing for us to keep in mind. So where do we come in? We're advocates. Pediatricians are advocates. Other people can be advocates too, but we're advocates for our patient while they're in the office. And for some of us, we're advocates for patients when they're outside the office on more of a global stage. So these things that I wanted to put up here, one, I just wanted to show you what it's like when a child is center, surrounded by family, friends, their school, their immediate healthcare team. Do they have access to healthcare or not? The surrounding healthcare system around them. Do they have insurance? Do they have access to things? We're lucky in this state that we have access to a lot of things that aren't necessarily available everywhere. And then what we call macro determinants. So environmental things, educational opportunities, cultural, political, social, economic factors. These are all things that are important and really shape a child as they're growing up. The American Academy of Pediatrics, has anybody ever heard of that group? They're in the news a lot recently. This is our parent group. So this is a group of pediatricians who gets together on a regular basis, and they have all these different specialty committees. They get together, they talk about what vaccines are important, what diseases are we seeing, what does the data show, and they make evidence-based recommendations that go out to pediatricians and other health caregivers so that we know what do we need to do at this point in time. But they might also have guidelines on what's safe sleep. What are some other safety things for kids? How do we manage certain diseases? And so we're very fortunate to have this group that uses science and evidence-based medicine to come up with these guidelines. And so this is something that's really important to all of us. And then lastly, I just wanted to talk a little bit about how people on a local level can get together and really make a big difference. So in 2014, I was sitting in a department meeting at the hospital, and somebody announced that there was a 1-month-old baby that died from whooping cough, what we call pertussis. And it was striking. When I was a resident at Cedars, we took care of some kids that were sick. Generally, the ones that had pertussis were not vaccinated. In this case, the child was too young to be vaccinated. So even if the parents wanted them to be, they were too young to get their first vaccines, but they were exposed to somebody else in the community with us. And it was something that I always wanted to do something, but I decided this is going to be the impetus for this. So I was playing catch with my oldest son one day, and I came up with this idea of strive for 95. It rhymed and it made sense. So what the 95 stands for is the percentage of people in a community that are vaccinated against a particular illness. So if you have 95% of your community that is vaccinated against measles, it is unlikely that if somebody with measles comes on vacation in Santa Barbara, that they're going to encounter enough vulnerable people that measles illness is going to stick and spread within your community. So if you look at the places in the country where there's measles outbreaks, by and large, their vaccine rates are well below 95%, and that's why things are spreading. And so what I decided was, what if I approached some other community leaders, other pediatricians? And so I found someone to work with, and the two of us went around to the health department. We went around to all the big health systems in town. We went to different school educators and superintendents, and we put together a coalition, and we decided, let's pool some money, let's put together a message. And so we launched this with some social media, we launched it with print media, some TV, some radio, we did some town hall meetings, all with the idea of helping to teach the community what this concept of community or herd immunity is, which is that 95% number. And I would say it resonated pretty well. This was a sticker we came up with. So if anybody's voted before, what happens when you vote? You get a little sticker that says, I voted. The reason why that's important to wear is people wear it and it's basically to say, I did something today. I did something for my community today that was important, and it serves as a reminder to other people. It's election day, I should go cast my vote and have my voice heard. So this idea was, what if we had parents that were interested in having a little sticker that said that they immunized their child that day and they were willing to wear it to Trader Joe's or Whole Foods or the shopping mall or to pick up their kids? Would that convey some message to other parents about, oh, maybe I forgot I need to get my kid in to get their vaccines, or I really respect that mom. She's always on top of it. I like to follow what she does. I want to follow her lead. If she wants to do this, then I feel like maybe that's something I should do. And so that was sort of our grassroots attempt. What I will say is that we collected a lot of data, sort of 2014 data and post-2014 data. We had some UCSB grad students who wanted to do the analytics on it, and we actually found statistically significant change that we made with this program, which felt really good. They were able to present it, publish it, help out with their graduate studies. And we had a model of what we can do in our community and elsewhere. And so when the pandemic hit, I pulled together the same group of people and we did some very similar things with masking, COVID vaccine, things like that. So you can make a difference locally if you have an idea and you're willing to push it. So I will say to this day, our county still has one of the highest vaccine rates of any county in California. And we just take a lot of pride in that locally. So that's the end of my talk. Just a couple takeaways. Patients we take care of are biologically dynamic, they're developmentally evolving, they're emotionally vulnerable, and they're socially dependent. They require their own approach, and where I come in as a pediatrician is I provide those things in a medical home and within the community. So I just want to end with restating the topic of this, which is children are not just small adults. They deserve an explanation, they deserve respect, and they deserve a voice. Thank you. And these are a bunch of my pediatric colleagues from the Sutter system. One of the nice things about us being part of Sutter is that we get to collaborate with other professionals, and being the 10th largest health system, we have a lot of resources, a lot of training. So these are some of my buddies I've gotten to know over the last year. I really love working with them. And I've got questions. So if anybody had some questions, anyone is pre-med or interested, you're welcome to email me. I'm more than happy to help you. We sometimes even have people come shadow, or I can try and help connect you with other opportunities if you're interested. This was one of my baseball teams, and I wore all of their buttons that day because they thought that was funny.
Thank you so much, Dr. Brennan. That was fantastic. And at this point, we'll have our interviewers come onto stage, and you can bring your chairs up here onto stage.
Thank you so much for the presentation, Dr. Brennan. My name is Deanna Shaposhnikov, and the first question would be, what inspired you to become a pediatrician rather than working in another area of medicine?
Great question. So I knew that I wanted to do primary care, and I was kind of torn between family medicine, where I would take care of babies up through the elderly, take care of the whole family, and I really liked that concept, versus just really specializing in children. And I really went back and forth on that. And so one of the factors was I wanted to come back to California. And the model in most of the places in California was pediatricians take care of kids, and a lot of the family medicine doctors took care of adults, but not as many kids. And so I didn't want to lose out on that opportunity. But really what it was is one of my pediatrician mentors told me early on, you're going to know what field to choose because you're going to be in a room of them, and you're going to feel the most at home as you've ever felt. And so what I will say is going back and forth in the snow to this clinic about half an hour from my house in upstate New York was a bit sketchy, but I looked forward to the drive every day. And when I left, I was not tired. I had so much energy. I was so excited to go back home and read about all the things I did. And that was unlike anything else. There were definitely some rotations where I couldn't wait to get out, and it wasn't my cup of tea. I didn't really vibe with the other people that were there. But when it came to the pediatricians, that was it. The other thing is I've always been comfortable around kids, siblings in our household. My brother and I are close in age, and then our sister is younger. So we grew up having a little kid in the house. We started coaching her soccer team when she was 5, and we would just always hang out with her little friends and that sort of thing. So my brother and I grew up really comfortable around kids, and so for me it wasn't a problem. I didn't mind runny noses and the sneezing and that sort of thing. You pick what is the bodily fluid that is least gross to you. So that's another way people look at it. So I didn't mind the snotty noses as much as some of the other stuff that I would have to deal with. So anyway, I loved it. It just grabbed me, and I knew it when I felt it.
Thank you.
Does that help answer?
Yes.
Okay.
How does pediatrics differ from other medical specialties in a way that it approaches patient care, maybe from what you learned in medical school or what you saw in different rotations?
Yeah, absolutely. So I think one of the important things about differentiating pediatrics from other medical specialties is we really have to approach the patient and meet them where they are. So if you have a newborn baby, we're going to spend some time with that baby, but really that visit's for the parent. And as kids get older, we start focusing more on them. So by the time somebody is coming in, they're 17, 18, it's less about the parent, it's more about my patient. And so I have to meet a person where they are, understand where they are developmentally, socially. How are things going in school? How are things going with friends? What things are they involved with? And I usually keep little notes like that. So when I see them the next year, I can say, oh, or, soccer, are you still playing soccer? Or are you still playing the piano? And so I think being able to connect with my patients and understand how things are going is important. But I think the biggest difference is we've got smaller instruments, we've got more kid-friendly art around the room, we've got smaller tables, we've got a table paper that's a little more kid-friendly. So and people really have to just be a little bit more in tune with making sure that child's fun. And we have stickers. Nobody hates stickers, so. We used to have lollipops, but we don't have those anymore. 0 to age 18, but everyone develops at a different time. And so I definitely have some patients who are 18 and they're ready to go off into the world and make their mark. And then there's others that just take a little bit longer. And so I do have some young adults who I've taken care of since they were born, and they still reach out to me in college. And so for them, I'm not going to call them children, but I still feel like there's still something there that's kind of pulling them to me, and so that's still fun to be able to take care of them too. But everyone's a little different. I'm sure you guys have known some high school friends who were adults from the time that they were sophomores, and they were just already off and on their way. But
thank you so much.
You're welcome.
Hi, my name is Jailynn Thomas. My first question is, why is pediatric care so important for a child's long-term health and development?
Great question. So pediatric care is really important to a child's long-term development because from day one, our shared goal with our patients and their parents are to make sure that their child is growing and developing normally. Those are the most important things. The role that I play is being able to support parents and their kids. It's being able to help figure out when something is not where it should be. So if their child's falling a little bit behind developmentally with their language or their motor skills, being able to recognize this, we're at a place where maybe we need to address this a little bit further, maybe we need to do an evaluation, get some therapy to help you, or being able to offer reassurance that there's a wide range of what's normal at this age, and so I think things are going well, you're doing a great job, here are the things to work on at home, let's continue to follow. And so I think for those kids who are with us, and we can track their growth, their nutrition, we can encourage them to be active, have healthy lifestyles, not spend too much time on social media, give a little bit of a heads up about things like vaping and other things that might be pitfalls for kids and their parents. That's that anticipatory guidance we were talking about. I would say that we hopefully do a good job with them, and then we hand them off and I push them off to college or their adult doctor or into their careers. Hopefully with them just having a good base because somebody was sort of part of their team, kind of looking out for them and advocating for them. Does that help answer?
It does. How do pediatricians use development milestones to access healthy growth in infants?
Great question. So one of the things that I didn't put up on the screen, but I probably should have, there are these crazy charts that show what normal development is. And so it's important for us to really have a good grasp of that. So that is a place where we do have to memorize what's normal for a baby at 2 months, 4 months, 6 months. Not everybody's going to hit the same milestones at the same time. So this sometimes happens when we have twins. One twin might be doing something a little faster than the other, or one sibling may have been more verbal than the other one is. And so sometimes parents are concerned because they'll compare the two, or they'll compare their child to maybe another child that's a neighbor or relative. So it's important for us to be able to keep track of that so that we know when to sound the alarm, when to do a little workup, and when to just offer the reassurance that's there. But early intervention is super duper important. So you're very lucky on campus to have this amazing Kegel Center that does a wonderful job with child development and screening kids for developmental delays. And so just right here on campus, you've got one of the world-renowned places, facilities. And it's so important because if we can catch somebody at an early stage that's maybe not hitting their milestones, we can provide whatever they need. And statistics show they really make big improvements if you can grab that early rather than wait a little bit. So I think it's super duper important.
For my last question, how do pediatricians account for cultural differences in child rearing practices when evaluating development?
That is such an important question. So it's important for us to get to know our patients. It's important for us to be familiar as we can with different cultures and practices because we know that that is going to have some impact. And we see this a lot with multi-generational families in particular. So a grandparent might come in and have some things that they want to see their child, who's the parent, do for that child. And sometimes the parent doesn't want to do that. And so it's important sometimes to understand a person's background or culture to kind of understand, well, maybe where is that coming from? Because then I might have a little more insight into how do I manage the situation where I have a multi-generational parent saying this needs to happen, and I'm looking at that child and thinking, I want you to have the best thing here. I don't want to have grandma and mom really butting heads. So we are fortunate. We get a lot of training throughout medical school and residency on that, and particularly at Sutter Health, it's really a big deal. And so I get opportunities for ongoing education on that on a daily basis. So it's important to keep up on. So I really appreciate that question.
Thank you.
You guys are so great with your questions.
Good afternoon, Dr. Brennan. I've really enjoyed hearing all your responses so far. I just have a couple more for you.
Of course.
My name is Linoy. Shalom. My first question for you is, how has working with children shaped your understanding of what childhood really looks like in practice?
I don't know if this will answer your question, but I want to give the example of I started as a pediatrician before I had my own kids.
Yeah.
And so I had one set of advice that I got just through my education and what my professors taught me. And that has changed over the years as I've had kids and I can relate more from a parent's perspective, plus just having more years under my belt. So I think to me, most of what I see every day is normal. Most of what parents are seeing with their babies is normal, but they don't necessarily know that because they don't really know their baby yet, or maybe they don't have the experience of being around so many different kids. And so I think the years of experience in doing what I do and then having my own kids and then coaching so many kids, I feel like that's really helped shape me into understanding all the different diversity that comes with growing up and being a kid.
Definitely. And then my next question for you is, what advice would you give to students interested in becoming pediatricians or working with children in healthcare?
Yeah, great question. So there are a lot of opportunities out there. So UCSB, I think, has a lot of really good resources. Sutter Health, Cottage Hospital also will have different opportunities available. There's lots of different groups in town that you can volunteer time with if you're interested. So I would say pick something that's interesting to you. Don't just do something because someone said it would look good on your application. Do something that you think you're interested in, that you can be passionate about, and then make connections with people. So if it's a pre-med advisor or it's somebody who's in the community, do that. If there's any students who have applied to school already or in med school and you have access to reach out to them and find out what helped and what didn't help, I think that would be a good thing to do. So I had quite a bit of help from the pre-med advisor at UCSB, who is a family friend, who really helped me shape my list of where I was ultimately applying. But I also had my own childhood pediatrician that was a mentor, and then a couple of other physicians that were family friends who were very helpful in just talking to me, reading my essays, kind of helping me shape what it is that I wanted to do. So don't be shy. It's okay to look up somebody and send them an email and introduce yourself and just see what you can find. Lots of shadowing is available. So.
Well, that's going to be it for our questions. I think at this moment we'll open it up to the audience questions if anyone wanted to get started with that.
Hi, my name is Mia Gutierrez, and I just had a quick question regarding legality. So you said that a lot of times with your patients that they're going through things, whether it be poverty or something like that. How do you go about addressing that with a child while their parent is in the room? Or do you ever separate them, or how do you go about that?
That's a great question. So it really depends on the age of the child. So for our teenagers in particular, we really like to offer the opportunity to have a one-on-one. We definitely have access to different screening tools that help us try and identify if there's something going on there too. So a lot of times when one of our patients is being roomed, they'll confidentially go over to a computer and they'll answer some questions, and that can give us an idea. We've got similar tools for families that are younger, and they can fill out some questionnaires, and that can help us identify if there's some things that we can help with. And then finding the support can be challenging, but we live in a town that's very generous and there's a lot of really good resources out there. And so if somebody's not already plugged into some of those things, we'll try and connect them, whether they need some extra help with food or they need some help with some developmental support for their kids, or a marriage and family therapist that might be able to help with a certain family dynamic that's going on. So definitely something that we take into consideration with every person that walks into the office every day to see, is there something else we can help with?
Thank you.
Great question.
Hi, my name's Chloe Gray. I was just curious, for us in the future, what would you recommend families to look for in a pediatrician if you're looking for a pediatrician for your own children?
That's a great question. So there are a lot of really great doctors out there, but I think it's important to find somebody who you connect with. So I think when it comes to choosing a pediatrician, a lot of it is probably word of mouth. So you talk to friends, you get some recommendations, somebody's OBGYN might give some recommendations. But in the end, we have families that will call and they'll schedule something that we call a meet and greet visit or a prenatal visit. And they'll either come into the office or we'll do a Zoom telemedicine type thing where a person just gets a chance to ask questions, get a chance to know, like, is this person responsive? Do they make good eye contact? Are they familiar with the things that are important to us? Are they willing to work with us? And just make sure that they're a good vibe and a good fit. So I would say word of mouth, asking your friends, and then ultimately, if somebody's willing to do one of these free meet and greet kind of visits, take advantage of that, because then you get a chance to really see if you click. And if you get partway into the relationship and it's just not a good match, that's okay. If you feel like there's somebody else who is going to be a better fit for you or your family, that's okay. We don't want somebody to choose someone and feel like they're stuck with them for 18 years. But I would say we're fortunate, especially in this community, that there's so many wonderful people out there that they'll all take great care of your family and your kids.
Awesome. Thank you so much.
Good question. All right.
My question, so my name's Nat, and I'm not really curious about pediatrics or being a doctor, but I was wondering what made you get into coaching Little League sports teams or youth teams?
Yeah, great question. So I grew up playing a lot of sports. My dad was very involved with helping to coach our teams, mostly because there was always a need for a coach, so he just stepped up and did it. But for me, it was a great way to spend time with my kids. It was protected time that I got to spend with them, get to know their friends. And later on, I found that it really was important because it could help us make sure we still have a good community locally of recreational sports to help give kids an avenue to have a positive thing to do after school, to get some exercise, to make some friends. And so I look at it as more than just the competition part. I really look at it as a chance for people to grow and develop and build communities. So part of the coaching and then being part of the administration part of that, it really was just like, how do we build something that's sustainable so the next group can come through and they still have fun sports to play. So what did you play?
I played baseball and then a bunch of other stuff, but that was when I was young. And then, so would you say you measure success not based on making it to state or something, but by the connections that they make?
Ultimately, did kids stick with it? Then you feel like, okay, you did a good job of making it fun, that they stuck with it. Did they make friends? Did they have a good time? And so those are the things. It is also fun to have the competition part where you can help train a higher level of athlete and be able to prove that with hard work those kids can get to further tournaments and things like that too. So there's definitely an advantage for those kids too, but the bottom line is just making sure that the kids are having a good time, that is a positive experience for them.
Awesome. And then I have a follow-up question too that you totally don't have to answer, but out of curiosity, what happened to your foot?
That's a good question.
Because of the boot.
So my foot got put in a timeout because I apparently was a little bit too active with it. So I had a little Achilles tendonitis, so it's in a boot just to calm down.
Just like overuse.
Exactly.
Well, thank you.
You're welcome. Thanks for noticing.
We did have a couple extra questions that were more just for fun rather than learning about pediatrics. One of them was, what do you enjoy most about your work and what do you do?
I really enjoy the fact that my practice is a community practice. Since I grew up here, a lot of people that I take care of are people that either I've known, I went to high school with, or my brother and sister went to high school with, or their neighbors or their kids that I've coached. and just being able to go around and see those kids. So when I go out to the high school, a bunch of kids come up and give me some next as being coach, or hi, Dr. Brennan. And so I think just being able to have that special role within a small community is really kind of what I enjoy most about my job. And then the other question was, what do I like to do? Well, when my foot's not in a boot, I do like to be active. So my kids don't need a coach anymore. I've sort of settled into doing a lot of refereeing. So I'll sometimes do 8 or 9 games in a weekend. Wow. And it's fun. It's a good way to stay in shape, but it's also a good way to stay involved with some of the athletic stuff out there. And again, it's kind of fun when you're doing a coin flip at the beginning and the kids are going, "That's my doctor." And I think they expect it's like I'm their teacher. They only expect to see me in the office, and it's kind of weird to see your doctor at Costco or out on the soccer field especially. So
it looks like you're a very vital part of a very tight-knit community. I think that's really special. Well, maybe another one of the questions from this list that we have here is, what do you wish more people knew about your area of expertise?
I think a lot of what I talked about today in just recognizing that the patients we take care of are just not small adults. So you can't necessarily take what is done in another part of medicine and just extrapolate that over to kids.
Right.
You really should be thinking about what is unique about this subset of patients and being able to provide that. So a good example would be the difference between an adult cardiologist, a heart specialist, and a pediatric cardiologist. So an adult cardiologist takes care of an adult human heart. The types of diseases and the conditions are taken care of are very different than what a pediatric cardiologist is going to be taking care of. And so I think just recognizing that a pediatric cardiologist isn't just taking care of a small heart, but they're taking care of a very specialized organ that's going to behave differently. That person comes with parents that you have to also really build trust, work with. So I think a very nuanced field. And I think somebody who's not in it may not really appreciate that nuance. So I think for my pediatric colleagues, just to get a little bit of some recognition for the fact that they do something that's very specialized, unique. I think just the acknowledgement of that would be a nice thing for more people to know. So that's part of the reason I thought it was really cool to get a chance to share that with all of you guys, just to give you a look into what we do. And you may have kids your own someday that you go to a pediatrician and you're going to decide, why do I need to go to the doctor? Do I want a pediatrician? Do I want a family practice doc to take care of my kids? So hopefully this will get in the back of your brain a little bit about what we do. And it goes back to that question about how do you choose a doctor? That was a good one.
Definitely. Thank you so much for that.
We also had questions from the audience as well. And one of the questions I noticed was from Brianna, and she asked, what are some adversities you faced in your journey in pediatrics?
Good question. One of the big things is our patients are sick a lot. And so in the beginning, I got sick a lot. And I would get sick from my patients. So I remember a particular day I was working in an emergency room in Los Angeles. And I walked in and they're like, here comes the resident sucker. And they stuck me in the room with everyone that had a flu. And within 24 to 48 hours, I've never been so sick in my life. And I think just the number of times kind of getting sick, I think that was an adversity. Other adversities are it's working and really with a tough situation. So a difficult diagnosis. They have an illness that you don't want to have to tell a parent. You don't want to have to tell a child to watch them go through a really difficult journey. I think it's hard for anybody, but I think it's particularly hard to see children go through that. And so I think that's one of the things that is also really a heart-wrenching thing about what we do. Fortunately, most of the patients we take care of are very healthy. But when you do find that one that's not, that's hard. It's hard to go home with that. It's also hard to separate out things that you hear during the day. And so as we're talking about what's going on in people's lives and you do uncover some of those things, that's sometimes hard to separate because you can't go home and tell someone about it. Everything we do is confidential. So it's not something I can just go tell my buddies, oh my gosh, I have this story to tell you. I have to keep it inside. And I think that is hard to do. So it's important to have just some outlets to be able to get out there and exercise or do something, have a hobby that I can take my mind off of some of that stuff. You have your hand up.
If you're aware of CCS, do you mind explaining the differences in care of a child who's under CCS compared to one who isn't?
Yeah, so CCS, I believe, is California Children's Services. And so, some of our patients who have developmental delays or diagnoses, they may have a diagnosis that qualifies them for coverage under CCS. So what those patients would be eligible for would be extra coverage, maybe for specialty care. They might qualify for some additional services, therapies, and things like that. So again, we're fortunate to live in a state that's very generous in that way. And so we do have a lot of patients that are under the care of CCS. So good for you for knowing that. That's impressive. And there are a number of things like that too, a number of extra little programs that exist. Sometimes they're just local programs, sometimes they're federally funded programs. So the federal government funds something called regional centers. Every county has a regional center. And a regional center is there to help identify, kids who have developmental delays and also to provide treatment. So if I have an 18-month-old that's delayed on their language, they're not picking up words yet, if I can identify that at 18 months and I can send them to the regional center to be evaluated and they're testing and they're qualifying for the services, the outcome for that 18-month-old getting services at 18 months for language is going to be much better than if we waited till they're 5 and they got to kindergarten and then the teacher says, gosh, you're really not talking a whole lot. We missed a lot of opportunity during that time. So early identification, early diagnosis, early intervention is tremendous. And I think it really speaks to a lot of the good outcomes that we see now with our patients who start off with delays.
Well, I think we can maybe wrap up at this point and sort of continue a little more informally. But if you would all please join me in thanking Dr. Brennan and also our first group and interviewers.
Nice job. Well done.